to another series, lecture in the social protection series put on by Bread IGC. Following last week's lecture on digital technology and social protection, we're very happy to have a lecture today on public health insurance, and I'm grateful for Radhika Jain, Assistant Professor of Health Economics at University College London, and Pascaline Dupont, Professor of Economics and Public Affairs at Princeton University, to share with us their many years of experience. And as I just learned, even a paper they presented yesterday on this very topic at Dartmouth. So we're very excited to learn from them. And we'll hand over to them in just a moment. But after I cover just one quick housekeeping item, which is that as we are getting emails regularly about attendance and verifying that, just to note that since there are hundreds, if not a couple thousand of you in the class, we won't be able to respond to individual emails checking attendance, but certificates will be given out to all those that attend 10 out of the 12 lectures as we shared previously. And as Anna shared in the chat, all of the past and future lecture recordings and slides are on the IGC website. So please do look at those if you missed a class or if you have questions and want to learn more. So Pascaline, I believe, over to you.
Before we do so, Caleb, sorry to interrupt the flow. We might just want to invite people to raise their hand to become live participants.
Yes, I saw your message of that in the chat, but absolutely correct. Like in the past lectures, if you are interested in having your microphone enabled for the live Q&A at the end, and preferably your video on throughout, so we don't just talk to black boxes. Please raise your hand and we'll sort that now.
All right. Thank you very much, everyone, for participating. Thank you, Caleb, for the introduction. It's my great pleasure to be here and share with my colleague Radhika Jain some insights about public health insurance in low and middle income countries. And I'm especially glad to be here with you as also wearing my cap as co-president of BREAD. It's always a great pleasure to see when BREAD is able to contribute to learning in the wider community. So welcome, everyone. I will present the first half hour of this lecture, and then Professor Jain will take over. And if you have any pressing questions, you can put them in the Q&A, and Professor Jain will try to collate them and interrupt me as needed as we go, but otherwise we'll keep the questions for the end, okay? So let me start with a figure from a recent paper by Das and Do that shows the tremendous increase in health insurance schemes in low-income contexts over the past 20, 30 years. It's really been very impressive improvements in the share of population covered by health insurance schemes. I'm putting quotation marks because we're going to see that, you know, there's some flavor of insurance, but some flavor that's not quite insurance in the schemes. So just as some examples in Rwanda, and I saw that there's you know, someone who said hi from Kigali earlier at the beginning of the Zoom. You know, Rwanda, the coverage has gone from 20% in 2005 to 83% by 2019. Turkey is another example, Indonesia. And if you contrast that with the experience of European countries, it took them way longer to get massive expansions. It took 60 to 70 years to expand from 10-20% at the turn of the 20th century to over 75% in 1975. So really the growth of coverage in low-income contexts has been quite remarkable, okay? And what's the rationale for this? Because, you know, you may wonder, because many countries actually already have an established network of public hospitals and clinics that, you know, already provided heavily subsidized and tax-financed care for people, okay? So if you can get care pretty much for free at the public facility, why do you need health insurance? And here the original idea was that, well, maybe you have a mostly free public sector, but maybe it's not doing exactly what it should be doing. Maybe it's not providing the type of care that people want. Maybe it's not providing the quality that people want. And in practice, you would see many people going to private sector hospitals and paying a fee for the care. Okay. And that results in quite large out-of-pocket expenditure, and that's inefficient. And we're going to see the theory behind that, because if the welfare of people can be improved if you shift their exposed out-of-pocket expenditure that happens all at once to ex-ante insurance. Okay, so for a given amount of money I'm going to pay for my health, I'd rather pay it bit by bit over time, as in advance, rather than having this big huge expenditure at one point in time when I fall sick. Okay, so if people are going to pay out of pocket at private facilities, insurance could benefit them. And the other issue is the fee-paying private sector is that it is inequitable, because the private sector is going to provide the care to those who are able to pay more, and so the poorest of the households may be left behind. Okay, so the original idea behind the public health insurance schemes was to try to fix this issue. Okay, and so we're going to go first through the economics of this, a little bit of very high level theory points, and then we'll go to part 2, which is going to be on the evidence of that. And we're going to see that there is sometimes a bit of a mismatch between what the theory would predict and what we see in practice. So part 1, the economics of health insurance. I just wanted to clarify one point that's sometimes lost, which is that the way through which health insurance can improve people's lives. Okay? And for that, we'll explore the concept of risk aversion, adverse selection, and market functionings versus market failures. So the first, insight is that really the benefits of insurance results from allowing people to spend their money when they need it most, not from lowering their overall health expenditures. Okay, so insurance is not the same as subsidies or cash transfers. Okay, insurance is about redistributing spending across states of the world. It helps you smooth consumption when the health shocks occur. Okay. So you can be better off from having, as I said before, spend a given amount of money slowly over time rather than all at once, okay? So your total expenditure does not have to reduce for you to benefit from insurance. So it's really insurance, the value comes from risk pooling and consumption smoothing, okay? So behind that, there is a concept of risk aversion. So why do people buy insurance? Because they are risk averse, which means that they prefer certainty over gambles with the same expected value. So very simple example, if you can, lose $1,000 with certainty versus a 10% chance of losing $10,000 and a 90% chance of losing zero, okay? The expected loss is the same, about $1,000, but most people prefer scenario A, okay? So what insurance does is that it allows people to pay a premium, a certain small loss, to avoid catastrophic expenses, an uncertain large loss, okay? And you can pay this certain small loss, every year. You may not have the catastrophic care needed every year, only once, every 10 years. So in the end, in the grand scheme of things, you will pay the same amount in total, but just spread over many periods, and that's gonna be much better for you if you're risk averse. Okay, so that's insight number 1, is because of risk aversion that the benefits of insurance really results from smoothing. Insight number 2 is that when insurance markets are working well, everyone who purchases insurance will benefit from it. But how much a given person is willing to pay for insurance depends on their level of risk and their level of risk aversion. Okay, so implications of that is that heterogeneity in the willingness to pay is very normal. Some people face a lower risk. So let's say younger people face a lower health risk. So they should, they expect to have less healthcare costs. So they should, want to pay a lower premium. And for a given health risk, more risk-averse individuals are going to value insurance more highly, okay? So that means that both less at risk and less risk-averse individuals are going to choose, sometimes not to purchase insurance because for them they don't need it. It's okay in a functioning market, the fact that people can choose how much insurance they want based on their own risk level and their risk aversion would be totally fine, okay? So in a functioning market, it's fine. Everybody can buy insurance at the level that fits their need. The issue, though, is that the market often doesn't function because of what's called adverse selection, which itself stems from an information asymmetry. What we mean by information asymmetry is the fact that maybe the buyers of insurance, the individual, is going to know more about their risk than the sellers will do, okay? And so that means that for the seller to pick up, a seller of insurance to assign a price that's based on my a premium, let's say that's based on my risk level, is going to be really hard because they don't have this information. But I have the information, okay? So for a given premium amount that's being charged, the high-risk individuals are going to be more likely to purchase insurance. Because for me, it's a good deal. For a given amount of premium, if I face a very high chance of having a very bad shock, then I should be more willing to pay for insurance than if I have a very low chance, okay? So why does this create a problem? Why does this create a problem of market unraveling? Well, it's because for a given amount of the premium, the high-risk people are going to be more likely to buy insurance. That means that you're going to have insurance among a pool of actually high-risk people. That means that the insurer ends up paying quite a bit to cover the high costs of care that these folks incur. So then they have to raise the premium to match that. As you raise the premium to cover the higher cost, fewer and fewer people are willing to pay the high premium. And the people who stay buying the premium are higher and higher and higher risk at the time as things evolve, okay? Again, because people who are low risk, they may at some point find that the premium is too expensive for their risk. It's not worth it for me to buy that insurance. You all have this experience sometimes when you're buying a plane ticket or buying something and they ask you, do you want to get insurance for it? Often the price of the insurance that they charge for that is too high compared to what you know of your risk of canceling your travel. Okay, so we have information about our risk, and based on that, we decide on whether to buy insurance. So as only the risky people, if you will, buy insurance, the cost for insurance increase, that increase the premium, that means fewer and fewer people buy insurance, and the risk pool becomes riskier and riskier. Okay, that's what's called the market unraveling. That in the end, you can't have you don't have enough people, or you only have the very risky people, and that means you can't risk share. Insight number 3 is that to solve this problem, when you have information asymmetries in the market, to solve this problem that some people are going to be excluded in the end, they can't buy insurance because whatever is offered is too expensive for them given their risk. You can solve this problem by well-designed policy interventions. So the first one, that's a very well-established result in the health economics theory literature, is an insurance mandate. So if you require that everyone purchases coverage, so you don't give people a choice, then essentially you force the low-risk people and the high-risk people to all be there together. And so you can truly spread, share the risk among everybody and share the cost among everyone, okay? So that the insurance mandate is very common in European context. In the US, this was part of the the Obamacare reform, as it's called. Okay, that's based on very sound economic theory. It's sometimes difficult to implement politically. There's been a lot of backlash against it in the US, for example. Another option is subsidized coverage, which is to make insurance affordable for all. So essentially make it cheaper for the low risk in particular. And the third option is tax finance coverage. So here's just like essentially moving away from the idea of having people pay premia and instead you do public provision or public financing, public provision with financing, with public financing of the care. Okay, so these interventions can restore market functioning and expand access. And a little bit more on this last option of tax financing. That's the one that's most common in low and middle income countries. Okay, where the government is gonna fund care through taxes rather than risk-based premia. And so that's really, in some sense, transforming insurance from risk pooling to healthcare subsidization. And in that case, you can, the people pay taxes based on their income or their wealth or their attributes, and not their health risk. Okay, so you're not now asking people who face a higher risk to pay more. You're using some other characteristics to decide who pays more. Okay, so it's shifting somewhat from insurance. But there are three major advantages to this, which is that you can with the tax revenue you can cover all expected healthcare costs, and so especially it can make it easier for very poor individuals to access the care. It eliminates adverse selection, because since you have a universal coverage without an opt-in decision or risk-based pricing, you don't have this unraveling that I was describing earlier. And in principle, since it can be fully financed, it should enable equitable access where everyone can receive the care. Okay. And because it's financed through taxes, and if you have a tax system where the relatively wealthier pay more taxes, then the costs are kind of redistributed based on ability to pay rather than health status. So in principle, no one is going to be excluded from this due to private information about health risk. So this adverse selection problem is completely taken care of. Now, the challenge is that the equity of this system depends on the design of the taxes. And in particular, it's often the case that it's the wealthier individuals that often consume more healthcare. Okay, even with universal access, in the sense that even if it's free, we often find in the data that it's easier for relatively higher income or higher wealth individuals to avail themselves of existing services. Okay, why? Because maybe they either they live closer to health facilities, or they have money to pay for transport to go to the facilities, or they are more likely to be aware of the benefits from getting the care. They may have more information about where to go. So if the wealthier individuals are going to be consuming more healthcare, and the healthcare is financed through taxes, then that can actually be, in some things, a transfer. It's not so much of a transfer to the poor. But so how it's going to finance is going to matter a lot for equity. If you have progressive income taxes, then you can achieve equity if the subsidies don't disproportionately benefit the rich. So if you can make it that the access to the care is somewhat equitable, and that even relatively poor individuals have access to the facilities nearby, then with a progressive income tax, it can be relatively equitable. If if this is financed out of a payroll tax, okay, it's going to depend on who ends up being formally employed. What's often the most regressive option is to finance it through VAT or a sales tax, because often the burden of that falls on the lower income households. Okay, so the bottom line is that in principle, you can think of a tax finance system as providing universal access, but it doesn't necessarily mean it's going to be equitable financing. And it's important to think about how revenue is raised, who bears the burden, and who receives the care. Okay, so this was just for the theory part and the reasons why you need some government intervention to help the market not unravel, for people to have access to care. Now let's talk about what we know of in the real world, these health insurance schemes, how have they done? Okay, so from what I've just described, you now have a sense that these public health insurance schemes is the dual goal of financial protection against health shocks, and expanding access to quality of healthcare. So it's a mix of insurance and a subsidy. So it's not pure insurance. It combines risk pooling with subsidization. And so what is the track record after 2 decades and massive expansions? We look at take-up and coverage, we look at financial protection, and we look at health outcomes. And the first insight there is that coverage remains somewhat limited. I mentioned, big successes at the very beginning, but it's not the case everywhere, and it really depends on the way in which it was done. So in practice, public insurance programs are far from achieving universal coverage. Subsidizing premia can increase enrollment, but it's not always enough, okay? So there's a review paper by Uli et al., and there's an hyperlink here on the slide. They estimate the mean coverage across 100 low and middle income countries to be 31%, with only about 8% in low income countries, 27% in lower middle income countries, 52% in upper middle income countries. Okay, so we're still far from having everybody having access to these schemes. And Das and Do, in a recent review, have 50% coverage across 62 countries. But they also, on average, but they also highlight wide variation and recent expansion for which we don't yet have data available. But what seems to be clear from a review that was done by JPAL of studies that have experimented with the amount of subsidies that people receive is that if you lower the premium that people have to pay, so you lower maybe the user cost, sometimes there is a premium and there is some deductible that people have to pay. But if you reduce the cost for the beneficiaries, you can increase coverage. But sometimes even very large subsidies fall short of universal coverage. So what this graph shows you that within Ghana, for example, a study randomized whether the subsidy was 0%, so no subsidy versus 100%, they find that this really increases the percent of individuals enrolled in a health insurance scheme. But in Indonesia, when you go from no subsidy to 100% subsidy, you only get to 26% coverage, okay? Or in Nicaragua, even with 100% subsidy, you only get to 36% coverage. So understanding why, even when it's completely subsidized, you don't get perfect coverage is an important question. And Radhika Jain, when in a few minutes, will talk about the potential barriers to access. In evidence insight number 2 is that there seems to be limited evidence of increased financial protection in the form of declining out-of-pocket expenditures, okay? And so here we can review evidence from 8 studies that find significant reductions in out-of-pocket expenditures, or OOP, as we call it. But those are the exceptions. So it's not that you always see reductions. So let's look at specific cases. I've mentioned on the slide, study in Ghana, Mexico, Georgia, China. These are examples where 4 studies where actually there were relatively large reduction in out-of-pocket expenditures. Okay, so you can think of it as like the program achieving their goal of reducing out-of-pocket expenditure. The most impressive one is in China, this large program where they show that the share of medical, the level of out-of-pocket expenditure did not actually change. People don't pay less out-of-pocket than they did before, but the share of total medical expenditure that's borne out of pocket dropped by 29 percentage points, okay? So we're going to come back to that point because it's important to think about whether we care about the level of out-of-pocket expenditure or the share of total healthcare costs that are borne out of pocket. Okay. There are other studies I list here where there is no or very limited impact on out-of-pocket expenditures. Okay, so I'm not going to go through all of them in detail, but they're just on the slides, and you have access to the slides. You can check those references. What's important is to think about how to interpret these results on out-of-pocket expenditures, because if you see no effect on out-of-pocket expenditures, as hopefully was clear from the first part of the presentation, this doesn't mean the program was a failure, okay? Because if insurance lowers the cost of service, that may induce more care, okay? And if you have higher utilization, So that means more visits, more procedures being done. Or if people are able to substitute toward, higher quality care, it could be that their total out-of-pocket expenditures are unchanged, but then they're actually getting more care for that. Okay. So that's, exactly the China case where there was an increase in utilization. The level of out-of-pocket expenses did not go down, but the share of the total cost of healthcare borne by individuals out of pocket really fell by a third. Okay. And that's really genuine financial protection. Why? And you can see that in this graph. This is from Gruber et al. This great paper that studies the China project, the China program. And they show in this figure the out-of-pocket expenditure for that individuals paid against the total expenditure. So before the program was in place, you can see it's like on a 45-degree line, almost mechanically. There is no insurance. So whatever the cost is, I have to pay out of pocket. Maybe there are a few cases where I pay less out of pocket than the total cost, maybe because I default on my bill. But for most of it, it's on the 45-degree line. But then after the program was put in place, you can see that, for relative low amounts of expenditure, people still pay, what the cost is out of pocket. But when they face very high expenditure, this is the type of catastrophic health expenditure that you want people not to have to deal with. That's where they end up paying much less after the scheme than they were before. Okay, so it seems that the program was very successful at reducing the risk of extreme levels of out-of-pocket expenditures, which is what you want insurance to do. Okay. Now, the last insight is about health outcomes. And here again, the evidence is somewhat mixed. Despite higher utilization, it's not always the case that you see better health outcomes. So consistently, people tend to see higher utilization of healthcare services and substitution toward higher quality private facilities, but it's not always possible for people to find improved health outcomes. Okay. And so I'm listing here some studies. There was no detectable effects on health outcomes despite higher utilization. And so the question is, well, why? What's going on? And that's an important question. But again, there are some notable exceptions. And in the China context, it's very expansive program that covered 800 million rural Chinese people. The Gruber et al. Study found actually a surprisingly strong result, because previous studies of the same program had not found much, but they were able to bring in new data that was micro data that was much better to look at this, and they find a decrease in mortality of about 20%, okay, 19.3%, and an increase in life expectancy as a result. So they say the success was due to essentially the massive scale of the program, the fact that it really expanded access to care. And they mentioned there were also some supply side improvements on the quality, but they don't think this is the main driver. So sometimes health outcomes improve, sometimes they don't. It seems like you see gains in health outcomes when the scheme is particularly successful at increasing preventative care, like prenatal health visits and early diagnosis, and also when it increases choice. So when people are able to opt for higher quality facilities or get access to better providers, and we have some references here on the slides on this. But we do have this puzzle as to why more care does not always lead to better health. And so the potential explanations are that the quality of care may not always be there. There may be some supply side constraints explaining the low quality of care, maybe lack of equipment, lack of drugs. And maybe the targeting is not great, and those who benefit the most from the scheme and increase their utilization are not the ones who need the care the most. Another very important thing to keep in mind is that measurement is tricky, and looking at health outcomes can be quite hard. It takes time for these things to change, and often you need a large sample. So when we say studies may be underpowered, it means that maybe the sample size is not enough to really be able to pick up on health outcomes, especially mortality. Okay, so in the China case, they had very, very big program and very large data sets, so they can pick up effects. Maybe in some other context, there's an effect, we can't see it in the data. Okay, but that's unlikely to explain it all. There's also definitely some cases where utilization increases and health doesn't get better. And that suggests that, insurance or insurance plus subsidy is insufficient and supply side readiness is going to be crucial. Okay. So I'm going to stop here and let, Professor Jen take over. The key takeaways from this part is that, from the theory, we know that insurance value comes from risk pooling, not, cost reduction per se. Market failures that are due to adverse selection justify intervention. Well-designed policy interventions can expand access, and often this is done in the context of this public health insurance scheme that bring the insurance aspect together with a subsidy aspect to help expand access even further. But from the evidence, it seems that getting universal coverage is quite hard, and subsidies are not enough. Financial protection benefits are limited in practice, except in some very successful cases like in China. And utilization gains don't automatically translate to health gains. And so this is now the key question as to why have results been so uneven and what is needed on the supply side to fix that. And so I'm going to let my colleague take over from there. Thank you.
Great, thank you. Okay, can you guys all see my slides? Okay. Okay, thanks. So I'm gonna pick right up where Pascaline left off and kind of focus on, why have the results on sort of the impacts of health insurance been varied so much across contexts. Pascaline also already kind of covered this a little bit, that, something to keep in mind as is that most lower and middle income countries do already have a heavily subsidized or entirely free tax financed public healthcare system. So in principle, households are already insured, but the public hospitals in these systems are paid through budgets and salaries, and there are very weak incentives for quality or penalties for low performance. And so in practice, the quality of healthcare at public facilities can be quite low, and there may be rationing where they're not sufficiently funded. And as a result, a lot of non-poor and many poor households opt out of the public system and choose to pay for care in the private sector, which means that they don't actually have insurance. And so to emphasize that Pascaline already mentioned that, something that's unusual about public health insurance is not just the insurance part, but the subsidy part. But something else that most insurance programs change. One, they may change how public hospitals are financed. So, shifting away from budgets and salaries to financing that follows patient volumes in some way. And this, the idea of this is it could change public hospital incentives. The caveat is, in practice, in many countries, this is not actually the case. Public hospitals continue to be funded through budgets and salaries. And so, in fact, their incentives don't particularly change, and they kind of continue doing what they did even before insurance. The second big change that many insurance programs bring around is that they add the option of getting insured care at private hospitals that are impaneled or in the insurance network. And so what this is doing is really a major policy shift away from direct public provision of subsidized healthcare to actually contracting private hospitals and providers for healthcare delivery. And as soon as you're working with the private sector, now it introduces the importance of prices, incentives, and provider behavior, and the dynamics of markets and competition and so on. So that's something to keep in mind as we go through this. Something that we, sorry, give me one sec. Let me just hide these. Okay. Something that, we emphasize in our chapter is that insurance programs around in various countries vary enormously in their design. So some key design elements may include, how is the program financed? Is it through is it through taxation, or are people also required to pay premiums or copays at the point of care? Is eligibility universal or targeted at the poor? Is enrollment automatic based on your poverty status, or is it voluntary and requires you to take an action? What kinds of services, how extensive is the service? Are the services covered under insurance? Many programs only focus on secondary and tertiary hospital level care, but other programs also cover preventive and primary care. Which providers are covered under insurance? Is it just public providers, or do you also cover private providers? If so, which private providers and how many of them? And then how are providers paid? So the design of payments, where you can, is it budgets or salaries, fee for service, capitation, and so, outcomes-based payments, and the generosity, how much funding, how generous are these payments? And, all of these design elements taken together, determine who gets care, how much care, and what type of care, all of which fundamentally shapes insurance effectiveness. And we argue that there's not amazing sort of causal evidence, but these factors may explain some of the variation in the impacts of insurance that we see across different country contexts. And there's quite a large economics literature in high-income countries, kind of looking at these aspects and how they affect and their causal effects on insurance impacts. And then there is a global health literature that's a bit more descriptive about this, but relatively little research attention in development economics on kind of causal stories around this stuff. Okay, so just to preview what I'm going to talk about in terms of why have results been so uneven across programs, I'm going to focus first on barriers to take up and some of what we know about that, and then secondly, kind of move to determinants of the quality of care people get under insurance and those links to outcomes. And specifically, I'm going to focus on two of the design elements we talked about, I just touched on briefly before. One is which providers, are covered under insurance, the provider network under insurance. And secondly, how are providers paid and, their sort of strategic responses to payments and how might that affect insurance coverage, insurance impacts. I doubt I'll have time to cover services, but if I do. I do also want to quickly say that, I'm not going to be able to cover every single aspect of insurance or every single aspect of these particular topics, but we're trying to focus on things that we think are important but relatively understudied. So starting with barriers to take up. First, it's important to keep in mind that there are two margins of take up. It can be enrollment into the insurance program and then utilization conditional once you're already enrolled. Now, there are some factors, sort of conceptual distinction to make is that there are some factors that can lower take up or enrollment into insurance despite people valuing and wanting insurance. And so this might include liquidity constraints where people want to buy it, but they just don't have the cash at the moment. Low or incorrect awareness about they don't even know the insurance program is or what it how it works, or they don't know that it exists, let's say, and then administrative barriers where like people want to try to enroll but literally are shut out because of administrative barriers in the enrollment process. And then there are also sort of somewhat separately there are factors that can actually kind of lower the expected value of insurance. So essentially, these are things that can increase the costs or kind of decrease the benefits people think they're going to get from insurance. This could include, things like informal charges. The care is supposed to be free under insurance, but in fact, people are charged sort of illegally, if you will, for the care by the hospital. It may be, limited coverage if the coverage of hospitals and services. So if there are not very many hospitals and they're not the hospitals people like, then they don't think the benefits that they're going to get from coverage are not that high. This could also link to things like distance costs. If the network of hospitals covered is very, very small, then the distance costs for people to get to the hospital may be substantial. There may be also limited coverage of services, which may lead to people being uncertain about, not everything being covered that they need, or people being uncertain about what is and isn't covered. There may be denial. So you think you've paid for, with your premium, you're entitled to care, but hospitals actually turn you away, or the insurer doesn't sort of honor the claim. And then there may be administrative hassles ongoing, not just the barriers to enrolling into insurance, but ongoing administrative hassles of using insurance, which may, there's kind of there's an opportunity cost to your time. And I think one of the comments questions was also about misperceptions. So it's also possible that people have incorrect understandings of insurance, and that absolutely could be corrected. But part of what I'm kind of pointing out here is that there may be also true costs and benefits to the costs of insurance overall. There may be sort of many sort of off the book costs of using insurance, or the benefits may not be what people actually value, and rationally so. And this is not necessarily just an information problem. And so all of these, things can lower utilization of insurance even once insured. But if people anticipate these ex ante, they think these are going to be problems or they know about this, then that can also kind of lower the expected value and willingness to pay for insurance and kind of lower enrollment for that reason. And these two sets of factors are, conceptually slightly distinct, but actually empirically fairly difficult to disentangle. So let's look at the empirical evidence first on the first set of things. There is very clear empirical research showing evidence of factors that limit take-up of insurance, enrollment into insurance, despite people wanting insurance. So for liquidity constraints, so there, there are studies that show large increase in enrollment when liquidity constraints are eased. So, for example, giving people a cash transfer alongside the option to enroll for insurance doesn't reduce the cost of enrolling for insurance at all, but we find that increased enrollment by 12 percentage points in India. So suggesting just having that cash made it easier for people to pay. There's also evidence, this is not exactly from health insurance, but changing when you could pay the premium so that you could do it at harvest time when you're not cash crunched can also dramatically increase take-up of agricultural insurance. Turning to administrative barriers, first, there are several studies that show really large effects of enrollment assistance. And these effects are the increases in enrollment are so large that, it seems unlikely that it's just, people couldn't be bothered. Like there's some bigger barrier there. But there's a study in Indonesia that kind of isolates this administrative barrier more cleanly. One, they document quite high rates of failures in attempts to enroll. So this is, people who literally wanted to enroll and went and tried to, but were unable to. So there's something, there's an administrative barrier there that's preventing them from doing it. And additionally, they find that even randomly assigning people, giving people registration assistance, someone comes and helps you, kind of enroll for insurance, increases attempted enrollment by 24 percentage points, but actually successful enrollment by only about 4 percentage points. And the reason in that context, it was because of administrative constraints. Essentially, enrollment is defined is done at the household level, which requires the state to have accurate lists of who's in the household. And so anytime there's, if someone marries in or is born and the household list needs to be updated, the administrative system was not flexible enough to handle that, and that was keeping people out. And then finally, on information, recent studies have found relatively small or no effects. In fact, the Indonesia study also gave people information about insurance, and this had no effect on enrollment rates. So I'm not saying it's not a barrier at all. It can be in some contexts, but it's perhaps not the most important one. However, so that's sort of the first set of factors I was talking about. But there still is this kind of puzzle. There is evidence of other costs and factors that may be limiting insurance take-up. First, again, the same Indonesia study, even when they gave a full subsidy and registration assistance, only 56% of people attempted to enroll in insurance. So there's still quite a large set of people that for even with all of this, with free, costless insurance in a sense, at least on paper, chose not to enroll. And that's kind of a puzzle. And it's not to say, like Pascaline said, we don't necessarily expect 100% enrollment, but this seems very, very low given this context. Secondly, it is true that there are studies that show that subsidizing insurance can increase subsequent, once the subsidies are removed, there is a slightly higher, people are slightly more likely to stay enrolled in insurance than without any subsidy at all. So there's some learning, but there's still dramatic drop-offs in enrollment as soon as subsidies are removed. So it's not like people experience the product, learn that it's amazing, and choose to stay on. Most don't. That could still be about poverty, and that they really needed the subsidies. But it's interesting that the same Indonesia study also shows that even amongst people who chose upfront to enroll in insurance without a subsidy, so they thought that this was going to be some product that they wanted, they document pretty large dropouts. amongst that set of people even over just a few months of insurance. So that's kind of suggests that it's not just an information problem, and in fact, quite often when people use the product, they're not compelled by its benefits to stay on in it. There's also quite a lot of evidence of difficulties in using insurance even once you're enrolled in the program. So there's, administrative and card hassles. So, difficulties using the insurance card at the hospital, hospital denials, turning patients away or saying that they can't get care under insurance, so they would have to pay. Pascaline and I and some people in Ghana also have, show unauthorized charges. So care is supposed to be free under the insurance program, but in fact, hospitals charge patients against program rules. And so all of this kind of suggests that, there are all these kind of off-the-book costs of using insurance that may be part of what's going on behind low demand for insurance. We also have some survey evidence in India showing that while this is amongst people that are enrolled in and using insurance, while they know about this is, the people that have filed a claim previously about insurance, even amongst that set of people, they do know about the insurance program, but there's huge uncertainty about which services are covered and which providers are covered under insurance. So first, this means that if you don't know what your benefits are under an insurance program, it's hard for you to accurately value it. But it also means that there's quite a lot of risk and uncertainty in whether your care is going to be covered when you go and try to get it. All of which could be another factor kind of lowering demand. And then lastly, we have one study where we show really striking large gender disparities in usage of insurance, again, amongst people who are already enrolled. Women and girls are much less likely to get insurance care. And this is the gaps increase in both in unauthorized charges by hospitals and distance to the hospital, which is another kind of cost of using insurance. So first, this shows that costs of care seeking under insurance can lower utilization of insurance. But another implication possibly is that if households are gender biased and value the healthcare of women less than females less than males, then the household valuation of insurance may be lower than the socially optimal valuation. In a sense, it's reflecting intra-household bargaining rather than the welfare of all individuals in the household. And since insurance decisions may be made at the household level, that may be a factor kind of lowering insurance valuations. But that's a bit speculative. And so, I think there are lots of reasons that potential reasons that insurance take-up may be low. I think it's very clear that administrative barriers keep people, even people who want insurance, out of it. And it's worth noting that quite often this is partly because these administrative sort of processes are designed to reduce inclusion errors, but as some of the targeting lectures and other lectures in this series kind of point out, there's this trade-off, like governments and policymakers are quite so often so focused on keeping the wrong people out of insurance that they may also keep the right people out of it. Second, I think it's, we talk about low awareness very often as a demand side issue, and there is some of that, but I think it's worth pointing out that actually it's not just a demand side issue, and that things happening on the design of these programs and what's happening on the supply side may contribute to it. Things like, when you actually go, spend time looking at these insurance programs, eligibility, enrollment criteria and processes, which hospitals and services are covered, it's all very, very complicated. It's frequently changing. And so it's not surprising that, awareness, it's difficult for people to fully understand what they're entitled to. It also means informing them, giving them accurate information to help them use the insurance program is going to be very complicated. More generally, I think, it's that these programs there's one thing on paper, but in practice, they can be quite difficult and in fact, risky to use. So things like, sudden denials of care once you get to the hospital or being charged out of pocket when you thought that care was going to be free and, that's why you went to care. That's increasing your risk on some level. And then there's evidence showing that, this kind of benefit uncertainty can lower demand, but it's particularly amongst the poor and the risk averse. And as Pascaline pointed out in her slide, the risk aversion is, risk averse are precisely the people that we want to be that would benefit most from health insurance. And so I think, in terms of areas for research, we need to understand a little bit better who is screened out. There is quite a lot of, attention on adverse selection, rightly so, but these barriers may also select on things like poverty and gender, and particularly in programs where the government is subsidizing the insured care heavily, this affects the incidence of those subsidies and the sort of equity of who benefit, of public funding. Secondly, it remains possible that people don't value these products that as much as we think they should, and we need a little more work to kind of really disentangle what's going on and understand to what extent this is the case and why this may be the case. And it's worth noting that program design, beyond premiums and copays, which have been studied quite a lot, there may be other program design aspects and what's happening on the supply side that may contribute to take up and warrants further study. Okay, so now turning to insurance quality and why, some reasons for why insurance may not totally affect health outcomes. And keeping in mind, Pascaline covered several herself. So taking the step back, thinking about what does insurance do? Insurance can shift people from getting no care into getting care. It can reallocate them across providers away from, uninsured care into insured care. And it can change the quantity and kind of care people are receiving, right? And so the net effect on health outcomes is going to depend on all three of these margins. And crucially, is going to depend on the quality of the providers and the care that you're getting under insurance. And so two important aspects of insurance design from those factors that I kind of mentioned at the beginning is one, provider networks. What is the quality of providers that are covered under insurance? And two, provider payments. So how are providers paid, and what effect do those payments and incentives have on provider behavior and therefore quality and outcomes? And that's kind of what I'm going to focus on next. So what do we know about quality? I'm not going to cover every single reference on this slide, but you can look them up. One, there is a huge range in most LMICs, there's a huge range of facilities from what I call kind of mom and pop hospitals, really tiny 2-3 story buildings, to really large multi-specialty hospitals. And so even the government, no one has a full census of all of the facilities in the market. Two, average quality is quite low. For example, medical studies have showed substantially higher post-operative mortality in LELMICs compared to high-income countries, very low levels of correct knowledge and treatment of various procedures, and there's substantial variation across providers. So, huge variations across different kinds of providers. Third, patients do perceive and respond to technical quality, but imperfectly. So, prices or market share can be positively associated with quality in different studies, but the association is weak. And so, essentially that the market is rewarding technical quality, but not perfect, not amazingly well, which is partly why there's, patients are only imperfectly able to perceive, to assess provider quality. And then lastly, improving hospital qualities in ways that translate into better outcomes has been very hard. And there's just a bunch, and most of these are RCTs of interventions from management support to accreditation, mentoring, clinical checklists, so on. Many of them find some improvements in compliance, but are less, not very much of it has shifted outcomes. Some of them, there is this concern about statistical power that Pascaline mentioned, but that not in all cases. So essentially, we're still not very good at figuring out how to improve quality at the hospital level, especially. So, first I'm going to talk, okay, so coming back to the provider coverage or provider networks under insurance and quality. In practice, so insurance, what kinds of providers does insurance typically cover? It usually covers all public providers, but we have evidence showing that in many countries, the quality of their care can be quite low. And then it covers private providers based on kind of measures of structural quality. So, usually empanelment criteria include things like, how many beds do you have, certain kinds of equipment on site, whether you have certain number of people on your payroll, doctors versus nurses and so on. which may or may not correspond to what's actually happens in practice. But all of these kind of, what in the health literature is called structural measures of quality have been shown to actually be quite weakly associated with the outcomes. And so which provider selection into, who should be covered under insurance is very rarely based on, good measures of quality and outcomes. So, that kind of sets us up for the point that like the network, which set of providers is covered by insurance is going to matter for quality, both relative to no care, as I was saying earlier, there's multiple margins, both relative to no care and uninsured care. Now, even that extensive margin effect, is getting some care under insurance better than getting no care at all is not totally obvious. So for example, this is JSY, which is it's not insurance, it's a cash transfer in India, but still, there was if the overall quality of facilities is low, in this program, it induced a quite large increase in facility-based childbirths, almost entirely at public facilities. If the quality of those facilities is not very low, it did not, in this case, lead to better health outcomes. It's also worth pointing out that given the empirical evidence of the enormous variation in quality across providers, plus the fact that patients are only imperfectly able to assess quality, which facilities are covered under insurance, and what this means for how people are reallocating from care that was before outside insurance into care that's in insurance is going to matter a lot, because what insurance is doing is and we have empirical evidence of this, that insurance programs do shift where people go because your benefits are only redeemable at certain sets of facilities, and there's evidence of this from several contexts, but we know much less about the how this reallocation from outside insurance into insured providers, how this changes the quality of care that is received. But it's just, again, worth pointing out that like on this margin as well, like, if you were getting reasonable quality healthcare outside insurance, and you shift to insured providers that are cheaper, but not necessarily better, in terms of quality, then you may you may not actually experience improved outcomes and possibly. So that was about, in provider networks and which providers are covered under insurance determines what the quality of care you can access. But provider networks under insurance can also change the quality of providers, right? So there's kind of a direct effect of patient flows. So, under insurance, the hospital is reimbursed based on what number of people or services that it's providing under insurance. And so this kind of directs patients to covered providers. This can increase volumes as well as revenue, and that creates the potential for those the influx of insurance money could create opportunities for them to invest in quality. There may be economies of scale, specialization, and so on. And there is evidence from Thailand and China, which Pascaline talked about quite some bit, that this kind of influx of money under insurance can improve outcomes. But on the other hand, if supply is constrained and financing doesn't particularly follow volume, and this is often the case in the public sector, supply is constrained because it's determined politically or administratively. It's not, hospitals don't have enough autonomy to invest or expand to adapt to more patients. And as I said at the beginning, financing, although on paper it follows patient volumes, in practice, public hospitals often continue to be funded through budgets and salaries, and the insurance money just goes back to the government. In that kind of context, it is possible that the influx of patients, encouraging patients to go into those facilities, can lead to overcrowding, congestion, and actually worse outcomes. And again, there's this nice Andrews and Vera Hernandez paper looking, again, this is more from the JSY context. We show it, but kind of demonstrating that this dynamic. There's another channel through which provider networks under insurance can influence quality, which is kind of through broader changes in competition and market responses. So one, there is theoretical and empirical literature from high-income countries showing that competition, when prices are fixed, so hospitals are not competing with each other on how much they charge patients on prices, then under those circumstances, competition can, they instead compete on quality, and this can improve outcomes. if, of course, financing follows patients and patients are able to assess quality to some extent. But that's kind of, that is very much in principle, in theory, the sort of insurance context, right? Where the insurance is kind of paying for care. And so now providers are just trying to attract patients based on quality. This could in principle be the one channel. There's also, it's also possible that these big insurance-driven investments in public facilities could increase competition and have positive spillovers on private facilities. We have some evidence of this from education markets in Pakistan and then milk ration shops in Mexico. But there's also evidence that it could actually lead to market segmentation and higher prices in the private sector. And there's some evidence of this from Chile. But all of this, these are things that based on theory and bits of evidence from various other contexts. But there's actually no, I couldn't find any empirical evidence specific to health insurance in lower and middle income countries on any of this. So I think there's no doubt that there are things like that. Insurance is having effects on healthcare markets, and there is competition plays a role, but we don't know very much about it. And so we really need, I think, we need more evidence on how provider networks. It's clear. It seems clear that provider network choice is going to affect quality. We don't have great evidence on how it does this. It's also possible that it could be a policy lever. If governments are deciding which providers to impanel in insurance, selective contracting based on some measures of quality could directly shape the quality of care people are accessing under insurance and kind of incentivize improvements in insurance. And there's a sort of tangentially related, there's some evidence from Kenya of the government successfully using sort of quality inspections and sanctions, the closures of low quality hospitals, improving the quality of care across the distribution of those who stay in insurance and, stay in the health system. But it really depends. This is not so straightforward. It depends on whether the government can assess outcome relevant quality better than markets can. There may also be this sort of trade-off between network restriction and access. So especially if the government gets it wrong, but and restricts insurance coverage to very few facilities, then that could make getting healthcare harder for people, and particularly if the government's wrong about that, that's actually problematic. And then there's medium and long-term general equilibrium effects, like I said, the kind of work through competition and markets that would need to be understood better. But it's possible that excluding the worst performers from insurance may be a starting point. But overall, I think there's really limited evidence on the quality of care outside versus within insurance. And, since this is an economics audience, it's worth pointing out that I think medical people sort of just measure overall provider quality, but actually what matters when we're thinking about the effects of insurance network coverage is which providers facility people actually use. So if you have a huge network of 200 providers, but people only use the five providers, then it's the quality of those five that almost everyone uses that actually matters. And that's why I added utilization weighted quality outside versus within insurance. We know very little about these healthcare markets in general, but also within insurance, and whether they whether the markets reward quality. We don't we need even descriptive evidence on prices, quality, market share, and so on. And then the kind of dynamic effects, as I was kind of saying, what does the introduction and expansion of insurance over time, what does that do to healthcare markets and quality and so on? Okay, so I'm almost out of time. Okay, and then lastly, I'm going to cover, provider payments and their effects on incentives and outcomes. So remember, as I said at the beginning, a major change in insurance is that they now contract private providers, and the idea is that there's private providers that are large. There's a large existing number of providers, so this can improve access. There's also private providers face market incentives. They may have because they're competing against each other. This can encourage them to exert more effort and improve their quality. But we know that private providers are also profit motivated, and they may prioritize their own revenue or welfare, but over social welfare. And so how these private providers are paid and the kind of oversight the government has over them are really key levers for shaping how the incentives and behavior of these private providers. Now, an important thing is that in most lower and middle LMIC health insurance programs, they use government administered prices, government set prices. So the government determines what how much hospitals will be reimbursed for various healthcare services rather than it being determined in the market. Now, as you can imagine, figuring what is that right price, what is the optimal price for services is conceptually is complicated, and there's a huge theoretical and empirical literature on kind of the trade-offs, in different kinds of payment systems, and evidence of gaming by providers, private hospitals, even in high-income countries. But they're substantially, the challenges of doing this right are substantially greater in lower and middle-income countries, where there's very limited data on hospitals, care costs, patients, how patient risk profiles, outcomes, and so it makes it difficult to adjust prices for very local variation in input costs, for risk adjustment for patient prior risk. It's difficult to monitor hospitals. Or kind of reward outcomes as kind of to offset the pure payment incentives. LMIC governments also have severely limited resources for oversight of these private providers and enforcement of insurance. And so there's just huge scope for gaming and misbehavior by private providers. I'm not going to go into the full, theory of various payments, but it's just worth kind of explaining one kind of payment that's very common in LMIC insurance. So fee-for-service payments is where the provider just kind of bills for everything that they do. Something that's increasingly common in lower and middle income countries is case-based payments, where there's a fixed price for a predefined kind of set diagnosis or procedure, and it's kind of a set of services or a visit almost, and that fixed price for that visit covers all costs. So you might have like a fixed price for a basic normal vaginal childbirth, and that fixed price will cover all the fees, rooms, regardless of how many days the patient stays, and so on. The idea is to kind of share financial risk, the up and downside risk with providers. If they spend less, they get to keep whatever is extra left over. And this can kind of encourage efficiency, discourage them from just doing too much because they don't actually, they kind of bear the costs of that and sort of control costs. But and this is part of the reason governments are moving towards it. But these kind of fixed payments also create incentives to cut necessary costs, not just unnecessary costs or over provision. So there may be incentives for patients to turn hospitals to turn costly patients away or skimp on care. They can also determine the profitability of services, so they can affect volumes and composition, and encourage hospitals to provide unnecessary but better paid services and less of the things that are less well paid, even if they're needed. And then lastly, the idea of a fixed price to the hospital is that the government pays the hospital that, and then the hospital provides care to the patient for free. But if there's weak enforcement of that last link, then hospitals may still charge patients. And then capitation payments are like an even higher level, where it's just a single payment for all services for a given period. It can have some of the sort of similar perverse incentives that case-based do. I'm not going to go this, but you can look at the slides later. There are, if you want to see examples of literally the price lists, case-based payments in India, in Ghana, Indonesia uses them as well. You can look at these later on. So some empirical evidence on how provider payments and specifically how provider strategic responses to payments can shape insurance effectiveness. There's some evidence, lots of descriptive evidence especially, but that fee for service, where the provider gets reimbursed based on what they do and what they bill for, encourages them to do too much. And in fact, insurance can exacerbate this because it kind of loosens the budget constraint. Otherwise, people who have to pay out of pocket, they're gonna protest if the provider offers them too much, gets them to do too much. And then I have a paper that's kind of looking at taking advantage of changes in case-based prices in India to look at how private providers respond. That paper finds that both the volume of services and the composition or complexity, whether you get a simple version or a less simple version of a service, both of those things are very responsive to price changes. In ways that that can lead to both necessary and needed and unnecessary care. So clearly prices are affecting the kinds of care or the type of care people are getting. And I can't perfectly look at effects on outcomes, but it's of course this is going to affect healthcare outcomes, right? And then secondly, the paper also shows evidence of hospitals of non-compliance with these administered prices. So basically hospitals are charging, so although the government sets prices to the hospitals are charging patients out of pocket additionally over what the government pays them. And some of this is compensating for the fact that the prices the government pays are too low, but only some of this. Some of this is just hospitals taking advantage of their position in the markets. And there's also evidence of coding manipulation. Where coding manipulation is where the hospital files a claim for something that is more expensive to make more money than what they actually did, which was the simpler thing. The Chokli et al. Find similar evidence of coding manipulation in Indonesia. And Pascaline, Yinshan Shang, and I have some ongoing work what we are finding is actually, while there is all this sort of over-provision, coding fraud and unauthorized charges, helping the government better detect and reduce these kinds of behavior is actually very, very complicated. And we have some ongoing work on that. It's not all bad. Everything is, there are, sort of more positive effects of prices as well. So the switch from in Thailand, switching from fee-for-service to a much higher capitation payment, but basically, increasing the payments to public hospitals dramatically increased service volumes and substantially improved outcomes, which does imply to some extent that low payments were constraining supply and kind of rationing supply previously. And there's some suggestive evidence from Colombia that capitation payments, provide this, like some kind of capitation payment actually encouraged investments in preventive care. I'm sorry I couldn't go into the details of each of these kinds of payments, but this is just to flag some of the ways in which payments may matter, and you can kind of read about them more afterwards. I'm not going to cover service coverage, except just to say that I think one thing, a lot of programs only cover hospital care. Some programs also cover primary care or preventive care. And as Pascaline kind of noted, programs that have tended to improve health outcomes better tend to also cover preventive and primary care. Even though those care, the hospital care is the most important from a risk protection perspective, primary care may matter and preventive may matter for outcomes. So ending our the two lectures, I think we want to make the point that insurance design fundamentally shapes insurance effectiveness. So all of those aspects that I mentioned, eligibility, insurance services, and so on, play a big role in how effective insurance is. Implementation quality and the supply side matter for impacts, but are kind of understudied. In terms of areas for future research, I think broadly we could understand better how kind of poor design and implementation affects take-up of insurance and the incidence who benefits from insurance benefits or subsidies. We need a lot more work on providers to strategic responses to insurance expansion and payment design. So, their entry into markets, their decisions on whether to participate in insurance, which patients to accept, what kind of quality to provide, whether or not to charge patients out of pocket, how much and how to bill the government. All of these, I think we need a lot more study on them and their implications for insurance effectiveness. Kind of more broadly, I think we could use more research on kind of looking at healthcare and insurance through the lens of markets, and this is something that economists can really add to the conversation, I think. And then lastly, there's not much research on this, but governments, I think, are desperately in need of evidence to help them think about how to design insurance and oversight mechanisms to limit gaming by private providers while maintaining their incentives to participate and provide high quality care, particularly in the context of LMIC governments that have severely limited resources for monitoring and oversight. And I think that's an area for further study as well. these are all very hard things to study, and we acknowledge that, but they are going to be really important for insurance. Okay, I don't know how to find my. How do I find my?
Okay, so we can open it up for questions. If people want to jump in and raise their hands or. Yeah, Lakshmi, you want to go ahead?
Sorry, just before we do that, if I could ask, given the time, if we could keep the questions brief to the point so that we can try to get a few, that would be wonderful. Thanks, guys.
Thank you. Thank you very much. Super interesting presentation. There's so many questions, but just one sort of tying this to the other classes that we've had. Are there studies that have shown how health insurance uptake is impacted by other social protection programs? Are there positive correlations, negative correlations, no correlations vis-a-vis other types of programs?
Yeah, that's a good question. I'm not sure that we know that actually. I'm thinking in particular about like when some programs are like cash transfers. I don't know if people have been able to look at the effect that had on take-up of insurance. I think maybe it's not been the case so far that a country has both a cash transfer program and this type of health insurance schemes that require payment. So that's a very good question. I don't think from the top of my head, I don't know of evidence on that. Coyote?
Okay. All right. Thank you for the session. I think I want to speak on and ask a question about the take-up, because I've noticed because of the amount of poverty for most of the people in the low-income countries, healthcare is not important most time to them. They have other challenges that they go through: consumption, accommodation, or even terrorism in the environment. How much does poverty contribute to take up? I'm trying to think about this. How much does it contribute to take up?
I mean, I take a bit exception with your statement that people don't care about healthcare. I think they do care about health quite a bit. And we find that when there is an emergency, we actually do end up getting, the emergency care and spending quite a bit of money on that. So, and then there can be this vicious cycle where, you have to, there's a malaria, the kid has cerebral malaria, absolutely needs to be treated. That costs money, and that helps, that contributes further to, impoverishing, I don't know if that's a word, making the household poor. But where you're right is that there are some aspects of healthcare that are a little bit more of on the luxury good side of things, like getting your blood pressure checked regularly, maybe going to do like mammograms, things like that, like more advanced care that people are not gonna seek because they're like, well, in any case, this is just I have to deal with the day-to-day. So there's a lot of demand for primary care, but then maybe not for the more advanced care, and so a lot of undiagnosed things among the the elderly, I may say, in particular, and that's definitely due to poverty, but also to the fact that sometimes it's just you have this long waits, all of the issue that Radhika mentioned can also be there, but yeah, for sure poverty is a factor. But it's not, I wouldn't say people don't care. I think they care, but they, about health. But how healthcare improves health is mediated by many things.
Yeah, thank you. I mean, me saying they don't care, not trying to say they don't care, but they kind of have other challenges that they are confronted with that makes not a priority most times. Yeah.
Yeah,
Thank you.
I mean, that they're constrained and that healthcare can be life-saving, but they have to choose between that and other things, right? And that's a horrible decision to make, which is part of why most governments argue, that we think that there should be subsidies for the very poor, that they shouldn't have to make those trade-offs between food and healthcare.
Thank you.
Yeah, Habib?
Maybe Habib moved on. Anyone else has a question? Or Habib, if you hear us, you can ask your question. We see you have your hand raised.
Can you hear me? Good afternoon.
Good afternoon.
Thank you very much, Pascaline and Jane. Your presentation has really improved my knowledge. I've learned a lot. I'm from Ghana, and particularly in the northern part of Ghana. I'm interested in the empirical evidence, the presentation on Ghana, the study that was conducted in 2016. In fact, that talk about the subsidy being low, zero, and then the coverage is high. I was interested in finding out the correlation because I know in 2016, the government has really budgeted about 6.7 billion for the capitation grant, covering the entire poverty endemic region, particularly in the northern region. So I was expecting for the study to rather tell me that with the government increasing the subsidy in the budgets, we should rather be seeing high coverage. But the study is rather to the other way around, whereby with the zero subsidy, we are getting high coverage. I don't know the reason behind it. So that is why I want more light, because I, particularly from northern Ghana, I realize that where the poverty is endemic, I'm expecting to see a lot of coverage by government budgets, where, for instance, the 2025 budget, we have almost about 10.7 budgets, 10.7 billion covering the various type of sicknesses in which people can easily walk to the hospital for care. But in other words, I don't know whether the study too was also talking about, for instance, the private, providers. If that is the case, fine, I'll start to correct it. Thank you and over.
Okay, are you referring to this graph that I showed in my slides?
Exactly so. Thank you. Yeah. This is
Yeah,
a graph,
so here
yeah.
it says that so this is the percent subsidy. When it's 0% subsidy, it means there is no, it's people have to pay. The take-up was 27%.
Sure.
When it's 100% subsidy, so it's free for people, it was 81%, right?
Oh, okay. Okay.
So
okay.
that's indeed, when
Okay.
people don't have to pay, the take-up is very high. So that's what's
Okay.
based on, yeah. So is that consistent with your experience in Tamale and
okay.
Amara?
But this one, does it cover both the government sector and then the private sector? I don't know whether the study was solely based on the private or is both the public and then the private sector. And beside that, the study was conducted in 2016. And I was expecting a new study should be conducted in 2020 to tell us the status of the coverage. That will go a long way to help me to appreciate these studies.
Yeah, I
Thank
mean,
you.
more, we always, I agree with you. More studies would be great. Right now, with Radika, our job was to bring together what we know of what studies have been done. But yeah, I would love for more work to be done on situation in Ghana. Yeah, absolutely. I mean, you can do it.
Thank you.
You're there.
Thank you.
So I'm just
Thank you.
looking
Thank
through
you.
some of the questions, and there's one here about, case-based payments. There's all these perverse responses to case-based and DRG type payments that LMICs are increasingly using, and what kind of institutional contractual measures can be like reduce these distortions in LMICs. What the whole, it is hard to do this. It is truly hard to offset, balance the positive and perverse incentives built into payment systems, even in high income countries. And so I can say that in high income countries, things that they do, they have a lot better data to be able to adjust the payments so that you're less likely to be overpaying hospitals. They can adjust them for costs. They can adjust them for patient risk. That, like, adjusting for patient risk means that hospitals are not super penalized for being in poor areas or in areas where the sickness people are on average more sick when they come to the hospital. Those kinds of adjustments can improve this, and so that's one strategy. That's again, the big part of my point was that these things are much harder to do in LMICs because the data is difficult. But in principle, that's one thing you do. Second, you can also use data to monitor case complexity over time. And so, the US Medicare also uses DRGs, and they are watching how, so they can flag hospitals that have systematically high complexity cases or weird combination, like 95% of patients have X procedure. And actually, what is great about some of these, like in some countries, like in India, insurance programs are generating this kind of data that was never available before, because all of the insurance claims are filed and reimbursed through electronic systems. And so Pascaline and I have been, that project that I mentioned at the end, we're exactly trying to do that, trying to use the administrative claims data to, it's very, very difficult to prove that a hospital is up coding, manipulating coding or over providing, but you can at least shortlist, you can at least flag the hospitals that look aberrant, which is exactly what they do in high income countries. Now this is possible in lower income countries. But then you need the government ability and wherewithal to use that information once we have flagged hospitals that look suspicious, to go visit them, do something about them, crack down on it, investigate, and so on. And so that can still be challenging. Another strategy that high income countries use, again, so that is to link. So you don't just, you have an additional set of incentives that are linked to quality and outcomes. So you've got your case-based or even fee-for-service, but then you might have bonuses for them achieving certain kind of quality outcomes. And again, for that, you need quality measures that are linkable back to specific hospitals, something that's very hard to do in LMICs. I think there is a broader point that actually, conceptually, I think the idea of going through the insurance and contracting private hospitals was to kind of, because they couldn't necessarily reform the public sector and they wanted to expand care, but actually working with private providers is very, very complicated and requires quite a lot of data and oversight. But yeah, I think that countries are increasingly generating the kinds of data that can help them improve this kind of hospital oversight. Okay. And then there was a question about whether selective contracting, deciding which providers are in networks, can genuinely encourage quality improvements, or does it risk deepening the divide between high and low quality providers? It's it's an empirical question, and a lot of that sort of slide was kind of speculative about things. We know that these things matter. We know which providers are insurance is going to matter certainly for people that are getting care in insurance. It seems very likely that it's having broader effects on the market. Whether it seems unlikely to kind of. The hope is that that if enough people if people go to the insured providers, which are good, and the money, reimbursements follow those people, then places that are really, really bad and excluded from insurance could in principle shut down. It's also possible that there's some kind of market segmentation. It's not beyond the realm of possible. And so, but that's the sort of thing where we need, like, it's very difficult to predict ex ante, and kind of need some research on that. I'm just trying to skim very quickly through questions.
There's a number of questions that were, okay, what's the most appropriate, what's optimal, what should we do, this is not a question for which there are answers, because there is never a one size fits all. I let Radhika add to that, but I think in general, like, there's, looking for a silver bullet in the literature is hard. So, the details and the nuances. So I just wanted to say that's why we're not answering most of these questions that ask us for like the one answer. It's much more complicated than that. But Radhika, if you want to add.
No, I think that there's, and certainly when it comes to payments, there's like theoretically, like the concept there, there is no optimal payment, but more generally, it is going to depend very much on quality, on contextual factors, and there's going to be interactions, right? So for example, whether or not you only restrict to public hospitals, and what impact that has on quality is going to depend on the quality of your public hospitals. The quality of your public hospitals may depend on broader institutional sort of capacity, governance, how public hospitals are sort of compensated both financially and in other ways, rewards, so it's really, so even this, I would not say that only channeling insurance through public facilities is bad. That's absolutely not the case. And in fact, some of the studies that show big impacts on quality were working entirely through public facilities. It's going to depend on the context, but we also know that in many lower and middle income countries, the quality of public care can be quite low and lower than many of the private providers. So yeah, completely agree that I think our idea is a bit more to flag the kinds of design aspects that may matter and some of the dynamics that may be at play. And then people working, whether from a research or a policy perspective in particular contexts, then have to kind of think about which frameworks or implications are kind of relevant for their particular context.
I think that we're gonna have to cut it off there. Sorry for everyone else who had questions. I'm sure that we could spend a few more hours here picking these wonderful brains. Big thank you to Professors Dupont and Jane for their time. And just to highlight, next week we'll continue kind of in a similar topical vein and learn more on job displacement insurance. So we're excited to do that and to see you next week. These slides and the recording will be put on the IGC website. So please check those out if you have further questions. Thanks everyone, and we will see you next week.
Thank you.
Thank you very much.
Thank you.
Bye. Thanks, everyone.
Yeah, thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
What do you think?